Welcome back, everybody. Can you hear me okay? All right. Well, it is really my great honor to introduce the afternoon sessions and to start with a colleague, Dr. Alyssa Apple, who is a professor and vice chair of the UCSF Department of Psychiatry. She's also the director of the UCSF Aging, Metabolism, and Emotions Center and associate director of the UCSF Center for Health and Community. Dr. Apple studies psychological, social, and behavioral pathways underlying chronic physiological stress and stress resilience and their impact on cellular aging. And she also examines these interconnections between stress, addiction, eating, and metabolic health. And in particular, Dr. Apple also leads two networks that are funded by the National Institute of Health, the Stress Measurement Network and the Network for Well-Being. So I think her insights both into kind of what are the hot topics that are going on right now in mental health and research and clinical practice, but also her experience with running these networks and what is the goals and the missions for these sorts of things. So Dr. Apple, really wonderful to have you. Thank you so much.
I'll do anything for Julene, so thank you for inviting me. It's an honor to be among musicians and artists. And just so I know who I'm talking to, raise your hand if you're a researcher. Oh, and researchers then, okay. So as Julene described, I run a research program for the past 25 years on the mind-body connection. And our recent studies, I'm a health psychologist, our recent studies have been getting quite focused on understanding different short-term interventions for depression or anxiety and how they are working through different mechanisms, natural interventions. And I'm on the, just to describe where I'm coming from, I'm on the board of a foundation that is solely focused on releasing integrative and natural endogenous means of healing for mental health problems and prevention and treatment. And so you'll hear some of that. My focus is interventions and mental health, so that's what you're going to hear. And I know very little about music, except for that I am, not just a music appreciator, but I certainly use it in my life, and at times, in my most difficult times, listening to music is a completely different experience in terms of its big impact on my well-being. So music for a distressed mind and brain, big effects, music when everything's great, small effects. Just pointing out that individual differences and where someone's at is one of those factors that is going to really determine how much change you see in a short period. We find that all the time. I just finished a two-year study during the pandemic of both people with high stress or people with depression. And we see tremendous improvements using natural daily methods to improve mood with people who start off with a very high baseline of whatever you're trying to treat, of depression, for example. Okay, so Jolene wanted me to give you, as a mental health researcher, kind of where we're at today. And since you see so many headlines, I'm going to keep this really short, almost to one line, which is that we started off with an epidemic of poor mental health before the pandemic, and things have skyrocketed to the extent globally in the last year. New article in Lancet estimates we have 120 million new people suffering with significant psychological disorders. And so unlike something like a COVID infection, the chronicity, the ramp down is slow, and so the mental health epidemic goes on, and the recovery might not be recovery, it might be a chronic lifetime disorder. So it's about living with symptoms. I want to mention the model of mental health that I am most excited about that is not mainstream, but there's research behind it. It was proposed by Keyes et al., someone who studies positive well-being. And it's simply this, that when we think about mental health, we think of a spectrum from severe mental illness, life disruptions, severe symptoms, to moderate, very common right now, to mild or none. And we just think, okay, where's your mental health? You're somewhere on the spectrum. And the goal of treatment is just reduce symptoms, get rid of the symptoms. Then automatically, if you get over here, you're flourishing. You have purpose, spirituality, good relationships, right? By reducing symptoms? No. So there's a whole nother dimension called this is called the dual continuum model. So if you think of mental health symptoms, we're all somewhere on the spectrum, and it changes. Then the other dimension is from languishing to flourishing, and it's somewhat independent. So you could have chronic depression, symptoms on and off your whole life, and tremendous amount of purpose, still positive affect, meaningful relationships, engagement with life. And it's all of those ingredients in well-being that we can think about as important in any music intervention, that we're treating the whole person. We're not just reducing symptoms, but we're actually helping them with creativity, with being, feeling that they have some control. So it's these aspects that we call well-being. I could define for you, because our network has spent months defining well-being. You can't really get researchers to agree very easily. It's quite an umbrella with a lot of ingredients under it. And so there's life satisfaction, purpose in life, positive relationships or connections. So these are beliefs we have about our life. So those are, reflections, and those can change, and they certainly predict things like morbidity, mortality. They're important. Then there's experiences that we have that we talk about as a fundamental building block of well-being, and that includes the spectrum of emotions. And it's not that well-being is predominantly positive and you're only having positive, and we all know that that would be very shallow and unrealistic, but rather it's the balance of emotions and regulating emotions well. And in fact, adversity in life, coping with different stressors, even uncontrollable ones, brings out growth, post-traumatic growth and well-being. And so we really want to try to separate the idea of, oh, you're a caregiver or you have a schizoactive diagnosis. You cannot have well-being in your life. And we want to think of interventions that really treat the whole person and increase well-being. We may never be able to get rid of symptoms for some types of mental health issues. Okay, so that is my mental health background. Now, what's to come? We have elderly people who, for sure, are vulnerable to social isolation and loneliness, but there's this resilience and wisdom that comes with older age and more positive affect. Their social circle is pruned to be more positive. So there's a lot of strengths. We have these kind of stereotypes of being older, and the fact is they're just not true. And in fact, our beliefs about those stereotypes, are predictive of negative health outcomes and earlier mortality. My colleague just wrote a book about that called The Age Code. But when we think about the current mental health landscape, it's the younger people who are the most vulnerable to mental illness and serious disorders, risky behavior, addiction, period. So for example, suicidality at the peak of the pandemic was increased to 20% in young people having suicidal thoughts, and it was 2% in older people. On top of that, looking ahead, our youth are looking at their future, and they're seeing very pessimistic headlines about the climate crisis and even deciding not to have kids. That's called the birthright movement. And a recent survey showed that 56% of youth in 10 different countries endorsed the statement, humanity is doomed. This is where we're at. So the mental health crisis is way beyond what we can even conceive, because it's our next generation. The idea that medications are going to help us out of this is absurd. I have a family with lots of different flavors of, I don't like the word mental illness, but just say challenges, and I know very well the mental health system and what drugs can do, and they absolutely have a role, and especially when it comes to severe illness and keeping people safe in the short term, they do not increase well-being, quality of life. In fact, they often reduce it. And it's interventions that target well-being that are missing. So that's why we have a well-being network, and that's where I think this music network fits in so well to our picture. It's kind of absent in the battery of interventions that we even look at to increase well-being. So I'm excited to learn, and I'm going to ask a few questions that will promote discussion and cross-disciplinary learning. One of the questions Julene told me to address is simply what makes a successful intervention team when you're trying to do this really innovative research. And so having a musician, a music therapist, a neuroscientist, if you have the funds to look into the brain, is really the frontier that's going to put this field on the map. And having a psychologist, someone like me, where you can say, I think a mechanism is this, I think it's doing that, and then we can say, good news, there's a measure for exactly that. And ideally, there'll be better measures than just self-report, but mostly we rely on self-report, which is easy to implement in any types of interventions. So the novel treatments that are coming up besides therapy and meds, which are important, especially during crises, but we don't have the reach or the workforce to reach everyone. Plus, they're not curative, as I was saying. So some of the novel treatments, the ones that we're testing are called Hormetic Stress. They stress out the body in the short term. And I won't go into it, but hyperthermia and sauna is on the edge of the future of one of these novel treatments, natural treatments to help treat depression. It's great for blood pressure in the heart, too. I'm studying the Wim Hof method, so it's basically like hypoxia. You're kind of hyperventilating and breath holding, and you feel like tremendous alertness, and it's changing things in the chemistry. And we found in the current study, we're comparing meditation, Wim Hof breathing, paced breathing, and mindfulness training. They all treat depression. So yeah, almost equally. Now we're looking into mechanisms and how long, and there's some differences there. But my point is there are many paths to wellness. Music is often part of them, even though we don't count it as an intervention. So in all of the plant medicine and psilocybin studies that we do, as well as the breathing studies, and some mind-body studies, we're using music. I mean, boy, it's a huge tool, and if we don't use it, we're not going to get as good effects, but we are using it blindly. And I was just talking to a music researcher. We're using it without knowing people's preference, so how far can you go with that? I just read Dr. Lenz's review, and I understand that music engagement is positively associated with well-being, social connectedness, emotional competence, but small studies. So, the idea of choosing your best, the best horse in the race to do some larger trials to put it on the map and get better funding is a really good strategy. It's not easy. I mean, we have done a huge review of exercise for depression. There's tons of evidence that exercise helps with depression, but no one talks about it or uses it. You don't see a doctor writing a prescription for exercise. And part of that is just getting people to do it. They need help. If they have severe depression, that's the last thing they want to do. So it's having the trained kind of coach to help get there. Okay, so back to use of experimental methods. NIH wants to fund experimental medicine trials. And that's not the only type of trials, but the idea is simply this. Just like they do with the drug trials, they put in tons of energy into dosing it and really working the development of the intervention before they will ever do a trial. And so they get it right more of the time because they have so much going into careful work into development. So in the experimental medicine model, you choose, for example, a music therapy that you think leads to an outcome, let's say a mental health outcome, with a mechanism that you're testing, and you think it's through a mechanism. And so with the science of behavior change, you're always testing a mechanism. Maybe it's social support, or maybe it's a biological mechanism, but you test in a small way to see, am I increasing the pathway or the mechanism? And you get that right before you ever go to a big sample and a big trial. So you're kind of having a small study looking at dose response. So in music therapy, I would imagine dose response is something that would be a high priority for the things that work to get that out there as an empirically supported gold standard practice. So what are this is really my question for you. What are the mechanisms that you would want to study that would make this get to a scientific level where you understand how different music interventions work? And from listening a little bit today and reading a few articles, it seems like some of what is being posed, like biomarkers, are not necessarily a mechanism. I'm a biomarker person, so I saw the autonomic nervous system, maybe cortisol, the neuroendocrine system, and my thought is, great, that's a validity check. Did they relax? That's not a mechanism. Well, I shouldn't say that. So the relaxation response is big and helps us a lot, but it's not durable and sustainable and long-lasting after the session. So it's more than that. I heard this morning a music therapist talking about emotion regulation. And so if that's part of what you think is happening during the sessions and then after in real life, there are lots of ways to measure emotion regulation. And this method of we call it the Science of Behavior Change, or SOBC. There's a whole network at NIH, so all sorts of networks, and we're all related. And the SOBC network has a great website if you just want to look up Science of Behavior Change NIH. And it just shows you that triangle of, get the intervention working so you're increasing the assay or the mechanism so that the outcome is more likely. You're controlling the outcome. So in that model, you could test things like the active versus passive listening, active music making, just side to side in a controlled intervention, if that's an important question. I was very interested to hear that reward activity as a mechanism, because I think that really opens music interventions up to strong, I guess, let's just say, our hardest problems, which are impulsivity and addiction. And of course, reward can help dull pain, and it can help with self-esteem and stress resilience. So it's a really one of our most important pathways to be activating. So I'm gonna stop there and just ask you, we don't have that much time, so I'll ask one question, and maybe we'll have time for one from you. And my question is, are there common mechanisms that we can even talk about, or is it, and I wanna know what you're thinking, or is it so dependent on the participants' goals and the type of music therapy? Yes.
The clearest case of mechanisms is in music and pain. So there's a lot of studies showing that music can help to reduce chronic or short-term pain, altering pain thresholds, and the two candidate mechanisms are either that music is hijacking the attentional system and so is distracting you, or it's having a mood-altering effect, and the neurochemistry that comes along with increased mood helps to act as an analgesic. Could also be both. But when you talk about these other complex problems that patients present with, like post-traumatic stress disorder or OCD or depression, I'm not sure that those are the only two mechanisms that there might be, but as you say, as an example, those are clear mechanisms, and the other things are just measures.
It's such a beautiful example. Thank you. I think chronic pain is such a well-known circuitry of pain response, poor coping behavior, and the neurobiology, and the placebo effect works. So we know a lot about the reward area, et cetera. So that's a great example. And as you were talking about more complex disorders, it made me realize that one thing this field could do early on is come up with a common set of mechanisms and characteristics of the interventions that you could then compare across interventions. So for example, attentional focus is not going to be the same for each intervention. For a music listening, which is passive, it might be focusing on the sensory experience of listening, but it also might be focusing on the more bodily interoceptive experience of vibrations in the body and body focus. It could be focused on negative self-ruminative thoughts because they're not paying attention. And you don't know unless you're measuring that. So, of course, that would just be a individual difference that would make it worse. But object of attention is important. So in meditation, we know, based on the type of meditation, what we think how we're focusing attention. So outward, inward, and whether it's a group or not, so whether they're perceiving support, and there's even physiological synchrony in dyads and probably in groups that we should keep in mind. Thank you for your question.